omusaayi mungi n'empisibwa bubi nnyo. Era ne ŋŋenda ku kitanda Mulago. Nazaalira mu Kisenyi ne ŋŋenda wa ne ŋŋenda Mulago. N'omwana wange era yafuna obugundi omukono guno. Ne batuwa ekitanda ne mmalayo ennaku nga 9, omutwe ne gunnuma, neefuna obulumi bungi nnyo. Neefuna omugongo ne gunnuma, amagulu ne gannuma, n'omutwe ne gunnuma. Nakosebwa nnyo kumala mwezi nga mulamba. Era obulumi bukyandika obw'omugongo, obw'amagulu, siri bulungi.
Soko nnyonnyole, wayiseewo bbanga ki ng'ono omwana omaliza omuzaala?
Omwana kati agenda mu P4. Ye.
Wayiseewo emyaka 4 naye kati okyawulira obulumi mu myaka 4?
Bulumi nkyabuwulirira ddala mu magulu, mugongo, n'omutwe gugira ekiseera ne gubeera nga kukola kigunnuma. Gusinga okunnuma nga ntudde awaka nga sikola. N'amagulu. Mpulira nzenna nga mbeera sisobola kuyimuka. Kasita ntuulako awo awamu. Naye we mba ntambula ate oluusi tebinnuma nnyo nga we mbeera awaka.
Lwaki baakutta nga tonnabawona?
Eddagala teryaliyo naye bampandiikira eddagala ne ndigula ne nsigala nga mmira obulumi obwo bukendeereko. Naye omugongo gwo gwannemerako gukyannuma n'amagulu. Naye nga baasigala bampa eddagala nti ogule eddagala eryo.
Bwe wava mu ddwaliro ewaka byagenda bitya nga bakutadde?
Nafuna obuyambi, abantu bampa obuyambi, ebyokulya n'okulabirira omwana wange era nga omuntu wayamba nti ono ali bubi. Banneighbours, baganda bange ne mbakubirako ne bampa obujjanjabi nga bangulirayo ne ku Makerere.
Omanyi waliwo ebintu bye tukozesa ewaka ng'omutwe gukuluma oba olubuto lukuluma. Bintu ki byakozesanga ng'owulira obulumi bukutta ebitali ddagala kuva mu ddwaliro?
Waliwo bino ebintu bye tutabula mu mazzi agookya, ebyo ebinaanuuka, mbitabula, mbigula ne ntabula n'ennywa. Na bino bihabohabo ne bagamba kola ki? Fumba onywe era nabyo nnywa. Nga wengula n'amakerenda. Kapisoozi, sirapu ebyo weebityo.
Kati bwe wakozesa ebyo ebintu byakuwako relief, owulira ng'oli beta oba just byasigala kimu?
Era ndabawo enjawulo, obulumi buba bukendeeramu. Nkozesa habo ne ku Makerenda, kapisoozi bwentyo.
Abasawo bakugamba ki ekizibu? Lwaki oli mu bulumi nakati emyaka eyisewo 4 naye kati okyali mu bulumi? Omusawo yakugamba kizibu ki ekikuluko? Omusawo
baŋŋamba genda mu maaso n'eddagala.
Kale tujja beera n'omusawo mu studio kati nja kuwayo chance omubuuze ekibuuzo ekikuli ku mind kikwata ku eno endwadde oba buno obulumi. Mubuuze omusawo waffe ajja kunnyonnyola nga ze mu studio. Musawo
mbanja ambuulire ki ekinnumya omugongo, musaayi guli gwe navaamu n'amagulu oba waliwo ekirala?
Thank you so much for watching. You have just seen Sophia's story. This is a woman that had a child and she had severe bleeding, she had back pain, she had knee pain, you know, her whole body almost shut down. And that is what we are here to unpack today, not just for Sophia, but really for everybody else watching that has gone through almost the same thing. So you're welcome once again. I'm Viola Kusasira, it's NTV Medical Matters, and we are supported by Bill and Melinda Gates Foundation. We have our expert in studio already. We have John Paul Bagala. He is reproductive, I beg your pardon, let me go through that. He is an Assistant Commissioner, Reproductive and Infant Health at the Ministry of Health. And I'll give him an opportunity to speak to us, perhaps introduce himself better, and then we can just dive into maternal mortality. You're welcome.
Yeah, thanks very much indeed, Viola. As you said, my name is Dr. Bagala. I'm the Assistant Commissioner for Reproductive and Infant Health at the Ministry of Health, and happy Liberation Day to all Ugandans out there. I'm happy to be back
You're welcome.
At NTV to, to discuss an issue which is very important to every Ugandan, surely. So thank you for having me back.
And you're welcome. We really like to have you here because we had the whole sequence of episodes go through with you concerning, the pregnancy journey and maternal health. So we've skipped forward to maternal mortality, but we shall be going back to the second and third trimester, as well as delivery and so much more within the pregnancy journey. But since you're here, so we have 189 mothers dying per 100,000 live births. And that is a very, very big figure. Looks small, really, but I mean, that's a whole life loss. So let's look at maternal mortality. From your experience, what has been the biggest cause, but also what hope do we have for mothers like that out there?
Yeah, thank you, Viola. Maternal mortality, as you've rightly said, and I think we slightly touched it in our previous conversation.
Sure.
You're looking at death of a woman during birth, all 42 days after the time of birth. And we also discussed that it can be direct or indirect, and we went through that. So yes, you've rightly stated that currently for every 100,000 mothers who deliver, we lose 189. Now, that is based on what we call the Uganda Demographic and Health Survey, which we undertook as a country in 2022. So every 5 years, we do that kind of nationwide assessment. The number is, of course, we've made some progress. We've made some progress because in 2016, for every 100,000 women who delivered, we would lose 336 by 2016.
Yeah.
So because of the efforts that we've put in as the Ministry of Health, strong leadership at the Ministry of Health, we've brought that number down. But still, for every single woman who dies, we get very concerned because for us, we look beyond the numbers. We look at this mother has a family. She has a society that she has been contributing to. She has people who treasure her. She has been contributing to the economy of this country. And so losing such a figure is unacceptable. So every maternal death is unacceptable to us. And we always have to dig deeper. We have to dig deep and ask questions to every single person responsible to how did we lose a woman during childbirth. So right now as the ministry, we have a program what we call the Maternal Perinatal Death Surveillance and Response, that for every maternal death that occurs in this country, we have to ask questions. Starting, we have to look for the journey map of that mother, whether she has died in a private facility, whether she has died in a public facility. And it's because of that level of accountability that we are reducing these numbers. And also we are trying to identify the system factors or the causes, as you've asked, which I'm going to go to next, that we're able to identify that the actual cause of this mother's death was A, B, C, D. And we have to do everything within our power to ensure that no other mother dies because of a particular issue. But back to the question. What are the leading causes of maternal mortality? We have three major leading causes of maternal mortality. One is bleeding after childbirth. Bleeding after childbirth is the topmost cause. And I think I was listening to the interview that you undertook.
Yeah, with Sophia.
With Sophia, yes. And she narrated that after giving birth, she bled a lot. So we lose quite a number of mothers, about 46% of the mothers that we lose are as a result of bleeding after childbirth. The second cause of maternal mortality is high blood pressure in pregnancy. In our medical term, we call it preeclampsia. It has a worse a worse type called eclampsia. So in eclampsia, you have a woman start convulsing when she's pregnant, and in most cases, for some of our people out there who may not appreciate, for as long as a woman is pregnant and starts convulsing, it's like that's a very dangerous situation for that mother. So it's another condition that, now it's a second leading cause of maternal mortality, and it contributes about 18% of the mothers that we lose. And the third, we call it sepsis. Sepsis, so sepsis, normally a woman has delivered, whether she has delivered normally or she has delivered through an operation, and then she gets infected. She gets an infection. And then the wound doesn't heal well because she's developing pus in there. So that is the third. And the infection, you know, as a human body, we have what we call bacteria, which is normal bacteria on our bodies. And so, but also there are particular things that we try to caution the mother that we've, let's say, operated, you know, that you take care of this when you're showering, try to make sure that the wound is dry. But also we start you on what we call some antibiotics, some medication, to ensure that the wound that we have operated does not get infected. So in some cases, we tend to get some women who have delivered and then they get some infection, and sometimes we don't realize it early, because sometimes some women, you know, tend to say that because maybe I've just delivered, that is the bit of pain that I'm feeling. Yet in the actual sense, the normal pain has already ceased, but we are getting a pain of a disastrous situation that is starting to happen. So in such situations, that's where we always say that for any mother who has delivered, there are particular things that we expect as norm. That if we have just operated you within 3 days, we expect that pain around the scar where we've operated to come down. If that pain is not reducing, or if down, you're starting to see that you're discharging some liquid which is not smelling normal, then you have to come back and we see you.
I was actually going to ask you, what are some of those you know, signs and symptoms that something is going off from what should be expected?
Exactly. And I'm going to narrate for what would you see for each of those three. Because, yes, for each of those three, what would you look out for you to say that I'm in the safe zone or I'm going into the danger zone?
Sure.
So I'll start with bleeding after childbirth. It goes back, for us to be able to address death of women during childbirth, it starts with preparing you before you deliver. Why? And you might remember, and some of our listeners might be remembering, that we discussed that the woman's body, the blood, the amount of blood increases in volume when she conceives. And the reason it increases in volume is because you are having another human being who is growing inside you. And this human being has a particular demand of nutrients, which if you aren't pregnant, the amount of blood that you had was just sufficient enough to serve your body demands. But with the other human being who is starting to develop, and the increasing demands that they are posing onto the mother's body, it pushes the body a little bit to adopt to that inner system that is developing, or the inner human being, to ensure that human being develops well. So one of the things that change, there are a number of things that change, but one of them is that your blood volume increases. Now, that is why in most cases, when a woman comes for antenatal care, and that is why we are saying that for every mother, as soon as you've realized that you're pregnant, go to the health facility And the most immediate sign is, I was having my periods every month, but this month I've not had my period. You go to the health facility and we find out why you've missed your period for that particular month. And the very first thing that we check is she pregnant or not? Because if we find out that you're pregnant, then we start preparing your body. And one of the things that we start with in the examinations that we do is that we check for the quantity of blood that you have. Because sometimes there are women who conceive, but when the amount of blood that they have is a bit low, and that has an effect on the baby, but also if we've not tackled that issue well in time, when that mother delivers, a slight loss of blood will take that woman into a situation that is very disastrous. Yeah. So that's why we must make sure that there are particular values of blood that we must work with this mother through antenatal care and ensure that her blood amount is sufficient enough that even when she conceives, that bit of bleeding that happens naturally after childbirth will not cause any effect to this mother. So that is why antenatal care is very important. So we start the journey of averting maternal death across all these three from antenatal care. Yeah. So every single mother who is out there, we want to encourage, please attend antenatal. Yeah. Now, once the time of birth reaches, and of course, we are trying to say that during antenatal, we are preparing you. We are preparing you for all that. Because there are particular women who are at risk of losing too much blood after childbirth. A case in point. If a woman is carrying more than one pregnancy, you are carrying twins or you're carrying triplets, you are at a high risk of having excessive bleeding after childbirth compared to a mother who is carrying one child. Yeah. If a woman has malaria and we did not detect it before she delivered, her chances of having bleeding excessively after childbirth are increased. If a woman is carrying a pregnancy that is more than the 5th pregnancy, or if a woman has delivered more than 5 children, yeah. In such cases, we have to treat you in a special way because you are in a category that where the uterus after delivering may need a little bit of boosting for it to contract back. If a woman delivered by cesarean section in the previous pregnancy, we have to really watch you very carefully because in this other pregnancy, there is a way that placenta, all what we call the way it implants, sometimes it can implant or it can station in the scar of the previous section. Yeah. And we have to watch because after giving birth, we have to be sure that that placenta is going to separate on its own and normally, because if it doesn't, then we have to come in quite quickly, find out the situation, and ensure that that placenta is pulled out quite quickly. The other issue is women who sometimes carry big babies. There are women who have delivered babies who are more than 4 kilos. Yeah. And sometimes you ask a mother and she says, which is okay. But some of those deliveries come with a bit of difficulty. And so we have to be a bit cautious. But also depending on how the baby is lying. Because sometimes the baby can lie when it's the buttocks that are, are down and the head is up.
Sophia's baby had legs first, actually.
She had legs first. So that was a difficult delivery. Yeah. That wasn't an easy delivery. So when you have the legs, if you don't have the head coming first, and you're having either, you can have a hand, you can have the buttocks, or you can have the legs. Those are not easy deliveries to conduct. And so we have to be super careful. So such women sometimes tend to get bleeding, excessive bleeding after childbirth. So those are some of the things that we have to screen you for. And we say that you must make sure that where you're going to deliver from, the facility is ready to encounter excessive bleeding after childbirth.
Do you think we're equipped enough as a country to handle that?
Absolutely we are. Absolutely we are. So we have different layers of facilities. Okay. We deliver from health center 3s. Now for us in our language, those are facilities that, yes, can deliver, they can attend antenatal, a woman can attend antenatal care from there, but they cannot operate and they cannot transfuse blood. Oh. Health center 3s. And that is also applicable for the private facilities. Now, if a facility cannot operate and cannot transfuse blood, that facility cannot handle a mother that has the other risks that I've talked about. So if a mother has been attending antenatal from that lower level facility and we've screened rightly and we think that she might have or she's at risk of excessive bleeding after childbirth, then we advise her to go to another level of facility. And that is what, so we have the health center 3. Now the next level of health facility that we send her to is the health center 4. Yeah. So the health center 4s are what we call the CMOC facilities, comprehensive emergency obstetric and newborn care facilities. Now those ones can perform a cesarean section, or they can perform operations, but also they can transfuse. Yeah. So it means that if a mother is delivered from a health center 4, so any facility that is a health center 4, it's able to perform those 2 life-saving interventions. So if a mother has delivered and she gets bleeding, excessive bleeding after childbirth, which we call PPH, then this facility would be able to transfuse if the woman needs a blood transfusion, or they will be able to operate. If let's say the woman requires to be operated before she delivers or during the time of delivery, they are able to undertake that. If the health center 4 realizes that this condition is a little bit beyond us, then they send you to what we call the general hospital. And if the general hospital feels like this would be a potentially complicated delivery, they send you to the regional referral hospital. Oh, yeah. And as a country, we have over 17 regional referral hospitals. Then the national referrals are basically for specialized cases, and those are really complicated. So the regional referral should be able to manage majority of the women who are delivering.
So doctor, going back to the 3 risk factors or the highest causes of the death, in mothers, we had high blood pressure during pregnancy. And so I've encountered a case where a woman had a safe delivery. I would say safe, she just had her baby, but later on she got, I think, a blood clot on the brain, and she just collapsed, and she got paralyzed. So right now she's under care for paralysis. So take us through the blood pressure.
So blood pressure, because I think we've exhausted the bleeding, excessive bleeding. So in blood pressure, still everything starts before you deliver. But very importantly, as we discussed, that there are particular signs that a woman should really look out for. If a woman is having persistent headache that is not resolving even when she takes some painkillers, mostly paracetamol, because that one, it's quite safe to be taken. Not every painkiller is safe in pregnancy. But so you take some paracetamol as prescribed by the healthcare worker, but the headache is not clearing. Then we have to check, is this woman having high blood pressure during pregnancy? Now, in most cases, those symptoms develop after 20 weeks. After 20 weeks of pregnancy. The other issue is that we have to find out, is this woman did the woman have, or did the mother have high blood pressure even before she conceived? Because there are situations where a mother can be hypertensive, and then when she conceives, the chances of that mother progressing into what we call preeclampsia, or even the most complicated form of high blood pressure in pregnancy, eclampsia, are very high. So we have to find that out. Then the other issue is, if the mother starts, you've gone past 20 weeks and you're getting, your vision is not clear, you're getting a little bit of what we call a blurry vision. Tolaba bulungi. Era tuchita oine chifu kumaaso. That's the question that we mostly ask. Now, that is a danger sign. That points towards, let's probe a little bit further and we see if this woman is not having high blood pressure in pregnancy. The other one, if a woman tends to get chest pain, now the issue is that chest pain sometimes is confused with peptic ulcers. But for a mother who is beyond 20 weeks, and then she comes and says, I have chest pain, they in most cases touch, the mid-chest. We have to probe and be sure she's not having preeclampsia.
I've heard about heartburn or something like that from the food, and
it is a bit different.
It's a bit different.
It's a bit different.
Okay, so let's return to that, doctor. Hold your thoughts on that. So we're going to take a commercial break. Thank you for watching NTV Medical Matters. When we return, we continue to look at what are some of the biggest causes of mortality deaths in mothers, and how can we make sure that we reduce the numbers that we are seeing in Uganda according to the Ministry of Health. Stay with us. Welcome back, and thanks for staying with us here on NTV Uganda. You are watching NTV Medical Matters. I am Viola Kusasira. You can watch on our X platform. We are streaming live, as well as on our website, to make sure you're part of this conversation, as well as call in and ask our doctor here all the questions you might have. We have Dr. John Paul Bagala. He is the Assistant Commissioner, Reproductive and Infant Health in the Ministry of Health, and he's here this morning to be able to get back to you on whatever might be concerning you when it comes to the journey of pregnancy and delivery. Today we are talking about mortality rates amongst women in Uganda, standing at 189 deaths per 100,000 live births. So you're welcome once again. If you're just joining us, you're also welcome on board. We are supported by Bill and Melinda Gates Foundation. So, Doctor, we continue talking. We were speaking about high blood pressure amongst women or pregnant women, and we're about to wind up on that, and then we'll go to pre-eclampsia. So let's go forward with that.
Yes, thank you very much indeed, Viola. And I can see time is moving so fast.
Very fast.
So high blood pressure, so having the chest pain, that's where I think we stopped. That's also a danger sign. Yeah. But also sometimes, because this pressure affects both the mother and the baby, sometimes the what we call the placenta can start separating before the baby is born. And in such a situation, the woman will get terrible abdominal pain. Yeah. Terrible abdominal pain. It's always generalized abdominal pain. So sometimes she may get that terrible pain with bleeding, but sometimes she may not bleed. In our medical term, we call it abruptio placentae. Okay. That the placenta is starting to separate before the baby is born. It's very common if a mother has preeclampsia. Then the other later one that I talked about, the most severe situation, is the woman starting to convulse. That is now the advanced level or the advanced stage of preeclampsia in pregnancy. That one we call it eclampsia. So all those are danger signs. But a woman can have preeclampsia during pregnancy, but even it can develop after she has delivered. The critical issue, like how Sophie was discussing, that she was having constant headaches. There are different causes of headaches. More so if at all, Sophie, if a mother delivers by cesarean section, sometimes they tend to get persistent headache after cesarean section. But also, as I discussed, that headache is one of the danger signs that can indicate to a woman that, oh, most likely your pressure is not in check, and so we need to do something about that. So those are some of the things that a mother can watch out for. But also very importantly, the mother can ask, whenever they go for antenatal, their blood pressure must be checked. So even asking that, musawo blood pressure yange it's very important. Yeah. If the healthcare worker tells you that the blood pressure is, below 140, the upper one, and it's below 90, the lower one, there you're within the safe zone. Because there are also parameters that we look at and say that, well, this blood pressure is quite on the higher side. So those are some of the quick things that we can talk about. Now, the other issue, sometimes, mostly when a woman is, almost delivering, they tend to vomit.
Oh.
When the blood pressures have gone up. It's not very common to all, but it's also another sign that we cannot ignore. The other sign that sometimes patients confuse is swelling of the feet, but that one it's not very definitive, because majority of the mothers, whether you have pressure or you don't, you can have swelling of the feet. So those are things that we watch out for. And as we said previously, that if you've had blood pressure in a pregnancy, please make sure that before you conceive, at least have a conversation with a healthcare worker. Because there are things that we can do to try and reduce on the chances of having preeclampsia in your next pregnancy. And there are some medications that we can put you on. Antenatal care still remains very important from a trained healthcare worker. And if you have preeclampsia, sometimes, when they tend to develop the eclampsia, which is like epilepsy. It's not muja kuloga, but it's a very dangerous state of a pregnant woman that we have to quickly rush out and try to save their life. If we don't happen quickly. Now, the issue is during pregnancy, the blood clotting capability is a bit high. We call it the viscosity of blood is increased. So sometimes, if the patient is not on any other medication, they may have, the potential of clotting is a bit high. But also in preeclampsia, what we talked about, that are you having a headache? Because one of the critical things that preeclampsia causes is rupture of small vessels in the brain. So a woman with preeclampsia, high blood pressure, can have a bleed in the brain. So it goes back to the other question that you asked, that they could have sustained a clot, but also the other possibility, if at all they had preeclampsia, they could have had a ruptured vessel in the brain, and that could have caused hemorrhage in the brain, which could have resulted into a stroke, and that is the situation that the stroke that we are now currently managing. So it's another complication of raised blood pressure in pregnancy. So that's why it's very, very important for us to take caution for any pregnant mother, look out for those danger signs and ensure that they're being managed appropriately. Then the other leading cause of mortality, as we say, is sepsis, or infection after childbirth. Now, very, very importantly, and we try as much as possible to tell our mothers that, in majority of our facilities, before you deliver, try to take a shower. When you take a shower, you're reducing on the chances of having that infection.
How am I going to take a shower when I feel heavy like a truck?
We try to help. Our midwives try to support and guide. But also too, we try to, if the mother has had a difficult delivery, like what Sophie might have gone through. Sometimes the difficult deliveries can predispose to chances of having sepsis. Now, there are these mothers of ours, the .com or the Gen Z mothers, who don't push. And for them, they go ahead and ask for a cesarean section. A cesarean section is not something that should be asked for. It should be done when there is a reason why it should be done. Because one of the complications, if it's not done appropriately, would be having sepsis after childbirth. So those are some of the things that we try to caution mothers about, and try to improve and encourage them on, issues related to the hygiene. As we give them the medication, those other factors also remain very, very important. Of course, everything antenatal, the nutrition, if your nutrition as a mother is not quite good, your body immune system is quite a bit low, the body cannot defend itself against some of these infections. So when you get something quite small, it gets into something that is quite uncontrollable. So all that we try to treat them as a 360 package for a pregnant mother, to ensure that we're not losing that mother during childbirth. The other issue that I had forgot as we leave this particular is during childbirth, around bleeding, is we try as much as possible to, when a mother is delivered, there are those quick signs that you know we have to watch out for. A mother starts asking for water, or the mother starts sweating immediately after childbirth. Then the most immediate thing that we have to check is this mother bleeding excessively. But also we try to caution that it's the mother at a facility is the primary person who should sound the alarm, if they can sound the alarm. If they can't sound the alarm, then their caretaker, we're trying to use that sort of approach, because in some facilities where you don't have quite enough number of hands, we try to monitor that bleeding that is coming out after childbirth. You know, a person can just keep changing pads, but keep changing pads, this blood is coming out of a human being. And during childbirth, we have to be very, very cautious that there is nothing wrong inside there that is, you know, causing the pads to be checked.
Speaking about that, Doctor, now, so how much of maternal mortality in Uganda can be, do you see being preventable, but also what role does the mother herself and the system, the healthcare system, play in this part?
A majority of our maternal deaths are preventable. Majority of our maternal deaths are preventable. Over 90% of the mothers that we lose are due to preventable causes. All those causes, the three, those are preventable causes. And of course, very importantly, as the women, the families, the men support women during pregnancy and childbirth. You know, delivering in facilities. We have a problem of the TBAs, traditional birth attendants. You know, non-trained healthcare workers who are also delivering. Now, there we are having lots of issues. So we are trying to say that let the woman, you do antenatal care. As we said, 8 contacts of antenatal visit during the 9 months of this journey. 2, you deliver in the facility. Then the other issue on our side is to ensure that we have healthcare workers available. We have midwives who are providing what we call treating these mothers with respect. On our side, we are ensuring that we are increasing availability of essential commodities and supplies. And that goes back to what we are saying, that if a mother is in a health center 3, is that health center 3 able to care for that mother at that level? But if she goes to the health center 4, is the health center 4 able to provide the other 2 life-saving interventions, that it has blood and able to perform a safe surgery. Okay. So those are things that we... So
Doctor, we have calls coming in. NTV Medical Matters. Okay, so you can call in right now. The numbers are on your screen. Call in and ask the doctor in real time the questions that you might have. We actually have a very short time to go. I just can't believe how quickly this has been. But if you have questions, please line them up and call in. The numbers on your screen, and the doctor here will be answering you in real time. So we continue with that. I have a question about antenatal. I just need you to emphasize that and its role in preventing all of this that we're talking about. For a mother watching right now and feels like, I always had my babies, you know, without having to go through all of that, what risk do they stand when they refuse to go for antenatal care?
Antenatal care is very important for any pregnant mother, and we cannot overemphasize that. And we know right now there are challenges that a mother will go.
Yes, doctor.
Okay, so they're coming for you. Yes, please, NTV Medical Matters. What's your question and your name?
Hello?
Hello, we can hear you. What's your question and your name? Yes, please. What's your question?
What are the causes of high blood pressure?
Okay. Thank you. Thank you for that. Anybody else on the line? We are ready to take your questions, and also go to our social media platforms at NTV Uganda. Make sure that you're part of this conversation, especially you who is there and you're a pregnant mother or you're in your journey to delivery. This is your time. So anybody else on the line? Hello, NTV Medical Matters. What's your name and your question?
Yeah, my name is Marternal, and I'm calling from Mbale.
Yes, please. What's your question?
My wife went through a severe infection, but the swelling has not subsided. And she's feeling a lot of pain around the scar, but also a headache.
All right, thank you so much. Okay, thank you. Thank you so much for that. Anybody else on the line? NTV Medical Matters, we are ready to take your calls right now, and the doctor will be answering you at once. So if you don't want to miss this chance, call in so that we answer at least 3 questions before we move forward. We're talking about mortality rate in Uganda, which is really at 189 per 100,000 live births. It's still a high number for me, according to my beliefs. And I know we can bring it down, you and I, if we talk. So anybody else on the line, your name and your question, please.
Yes, thank you. This is Isaac calling from Bara.
Yes, please.
Yes, now I would like to know how the doctor handles the issue of referral, because most of the deaths which really happen at the lower facilities is because of delayed referral.
Oh, yeah. Okay.
Yes, you find the medical personnel access, and maybe you are even realize you may not handle these conditions, but then the delay referral. By the time they are referring, the patient is weak.
Okay, thank you so much.
Yes, thank you.
Thank you so much for that. He's calling from Bara, I believe, Isaac. Anybody else on the line? We take our last question and we get into answering them. NTV Medical Matters, maternal mortality is the topic for today. You are watching a Vilaxa show is supported by Bill and Melinda Gates Foundation. This is our Dr. John Paul Bagala. So call in and tell us. That is our last caller. So what's your question and your name?
Good morning.
Good morning. What's your question?
What thank the doctor for that initiative and we said
Yes.
After cesarean, what is the cause of the swelling of that scar?
Could you please repeat that?
What causes the swelling of the scar after the cesarean?
All right, thank you so much for your question. Oh, wow. Yeah, our viewers are really attentive, and thank God you are taking those down so we can dive into them straight up and answer them in real time. Anybody else, you can also send your questions, put them on our social media platforms, and we shall always get back to you. So, Doctor, go ahead.
No, thank you very much, and I'm very happy it's men who call. So for all the men, please, as men, we are the center. And when as men we get our hands onto this issue, then we are saving our wives, our daughters, and our sisters.
Absolutely.
So thank you to all the men that are listening in out there. I'll start with the latter and tie it up with question 2 on the swelling of the scar. So whenever you get, and sometimes we tend to see this, when you get a small cut on your body, it may not be a cesarean section, but as that wound heals, then the tissue forms a bit of a bulge. But it varies from person to person. And during the healing process of that wound, there are particular fibers that form. In the entire process of wound healing, there are particular fibers, then the cells come together, then they cover the wound, and then the body starts, taking its natural course of healing. Now, in most cases, some of those fibers are supposed to be broken down as soon as the scar has been formed. But in some situations, the fibers are not broken down, and they would form what we call, in our language, we call it a hypertrophied scar or a swollen scar, which colleagues have been talking about. But not every person who has a cesarean delivery goes through that. It's because of the body's failure to break down that tissue that aided in the healing of the scar so that it resolves. Now, that is one. But also, that swelling of the scar, the mother will have it until the next delivery. If she's to deliver, because when a mother delivers by cesarean section for the first child, it's not that the next child will be cesarean section. No, we give you an opportunity. So there is what we call trying labor after cesarean birth. So we try labor. But of course, we watch you very carefully. Now, if at all you are to deliver the next baby by cesarean section, we cut off that swollen scar. So we first incise it off and try to repair the skin without the scar. Now, of course, some bodies it may not recur, but in some bodies it may recur.
Would you like to tell us what could be the cause of the failure to break down the fibers, and is there a way a mother can improve their immunity?
No, so what we do in most cases, if a mother has that history, that yes, all my scars swell, there is a particular medicine that we inject into the scar to prevent the scar from swelling. So it's always very important that any mother who has that swollen scar, as they are attending antenatal, you know, or even at the time, you know, as for people who have planned cesarean section, those are cesarean sections that we do when they are not in emergency situation. You know, you tell the doctor that, can you please help me to prevent this scar from swelling? There is that particular medicine that we inject into the scar, and it tries to prevent recurrence of that solid. So we try to help the body in dissolving the scar tissue. Now, the other question that came through is causes of high blood pressure. So there are various, and I should say, theories that have been put forward. But one is, as the baby is forming, and I will try to make this in the simplest language possible, and quick, because it's quite a very long explanation. But as the baby is starting to form, the baby, you know, as soon as the mother conceives, the baby starts forming. But of course, there are different stages of baby formation. Now, as this baby starts to form in the earlier phases, you know, it starts as one small cell, and then the cell starts multiplying. Now, that baby implants in what we call the inner lining of the mother's womb. As soon as it implants, the mother's body starts responding automatically. Now, one of the responses that the mother's body makes is that the blood vessels on the mother's side have to readjust to connect with the placenta, which is starting to form. And one of that readjustment is what we said, that the mother's blood increases. But also in that increase, these blood vessels must a little bit expand to be able to accommodate that increase in blood volume. Now, in most cases, some blood vessels don't, in our language, we call it remodeling. They don't change quite well. So that is one of the theories that has been put forward to potentially cause blood pressure. But even up to now, we are still doing research extensively to find the actual cause of increasing blood pressure. But there are other particular theories that have been put forward. And the other one is that, and that's why I was saying that if a mother has multiple babies, the chances of them having blood pressure, it's not that every mother who has multiple babies, and those are twins, triplets, will have, but the chances are on the rise. And the reason is that the other theory that has been put forward is that there is a particular component that the baby forms as they grow. Now, when the mother's system is exposed, in our language we call it the amniotic villi. That's the language that we use. So exposure on increased quantities of that component, the amniotic villi, raises the chances of that mother having preeclampsia. So that's why a mother who has more babies, they will have more of that component, and so their chances of getting blood pressure are high. Now, the question was, what causes blood pressure? Now, those are some of the theories that have been put forward in terms of causes. There are also two other theories which I may not explain. But there is also another issue. What are the risk factors? How can someone know that, oh, I'm at risk of having blood pressure during pregnancy. Now, to our listeners out there, that may be quite a more, that may be easier to look out for. That, as I said, if a mother has more than one pregnancy, if a mother had preeclampsia in the previous pregnancy, the chances are high. If a mother, you know, is of advanced age, all early in pregnancy, advanced, all quite young. There are those first-time mothers who are quite young, all mothers who are about 35. Those are just increased risks. But also if a mother has underlying conditions.
Does body weight and food and perhaps diet play a role in that particular space? High blood pressure?
For the weight, yes, it does. The weight is the other risk factor. But the diet, we haven't had studies that are conclusive on the issue of diet. But the weight just increases on the risk of having high blood pressure. So those are some of the risk factors that a woman needs to look out for. Now, if a woman has diabetes, and she conceives when she has diabetes, the chances of having high blood pressure are also on the rise. And finally, if a woman has a heart condition, or if a woman has a kidney condition, there are chances. So those ones we have to look out for, because all these critical organs have a critical role. And our final question was referral. Now, and I like Isaac, he really asked a very important question on referral. And he put it very rightly, that one of the issues that we've had is for mothers that we've struggled to refer appropriately, the outcomes haven't been good. So as the ministry, we've established what we call local maternity and neonatal systems. The local maternity and neonatal systems, these are regional mechanisms for maternal, to coordinate maternal referrals. And it's mostly amongst healthcare workers, that if I'm in a lower facility, whether it's a private or a public facility, and I have a mother before me whom I cannot manage, I alert immediately, virtually. I make a call to the higher level facility, and I inform them that I have this mother, is with this, but this is beyond our scope. Please prepare to receive the mother. We are sending the mother. Now, the other issue that we are working on as a ministry is to ensure that once that call comes through, there is an ambulance available. Because what we've received in some situations that the call comes through, but the mother goes through private means. But in most cases, this mother needs to be supported, depending on the condition with which they are moving. So because we are trying to see how do we increase on the number of ambulances that are available, so that every mother who is being referred from the lower level facility to a higher level facility is transported through an ambulance and being accompanied.
You say that as the ministry, but do you think that private workers, for example, health workers who are also handling these mothers, understand the urgency in that?
And that is what we want to really them to appreciate. We want them to appreciate that if you are a healthcare worker at any level, at any facility, get to appreciate what you can handle at that level and what you cannot handle. Because, and we are taking it that this mother is being cared for by a trained healthcare worker. It's only a trained healthcare worker who would be able to establish and say that this mother is at the level where we cannot deliver her at this facility. Now, we have to do that, and for my fellow healthcare workers out there, I really need to urge them that make that decision quickly and early, because this mother came to you in time, sometimes. And I want to thank the men out there, because men are starting to do their job in terms of ensuring that the women are attending antenatal, the women are getting to the facilities early, and also to encourage men that the woman should never say that I cannot go to the facility because I don't have transport money from home to the facility. So as men, we have to play that part, so that there is no delay. There are three major delays that we're looking at here, and still ties into that question, that there is a delay for a mother to identify a danger sign and say, oh, I'm in danger, I have to go to the facility. That's the first delay. The second delay is the mother has identified a situation she's in danger, but how she gets from home, or how she moves from a facility to a facility where she'll be cared for, there is that delay. And that is something that we have to fix intentionally.
I'm imagining, partnership between government hospitals or those health centers and private caretakers or health workers. Would a private health worker be willing to say, for example, I cannot handle, let me send to a health center, say 4?
Yes.
Do you have that kind of existing working relationship?
Exactly. For us as government in our facilities, a mother coming from anywhere, we receive them with open arms. And why? Because if that mother dies somewhere, we will have to ask the questions. And we must, through the other broader regional mechanism that I've talked about, which we've established at the ministry, the local maternity and neonatal system, for every maternal death, we have to we ask the regional referral that is taking that region, because we have 17. Every regional referral has a local maternity that is, supervising it in terms of deliveries, mothers, babies, and children. So if a mother dies anywhere, whether it's a private facility or it's a public facility, the team from that regional referral hospital will come down and investigate the circumstances that were surrounding the death of that mother. So any private facility, and our numbers are very available. We are being called, we are receiving calls from anyone. For us as ministry, it doesn't matter. For as long as this person is a pregnant mother, we receive calls from anyone and we're able to guide on where they can receive the care. And that's the only way we will reduce the 189. We don't want to see any mother die because of a preventable cause. I
like that part where there is supervision, because you see those numbers, when you bring them in, these are numbers coming from everywhere and anywhere and any mother and every mother, but then the ministry and government, you have your own agenda, but then you have somebody playing privately, so I like the link there. So let's look at the mothers who give birth in hospital carefully, successfully, very well, and they go back home. Within just like a few days, they have a bit of a fever or a cold, and before you know it, they just die. What has gone wrong there?
Oh, that's quite an interesting question. But of course, very importantly, what you're talking about is now postnatal care, the mother's delivery. How do we ensure that that mother is care? Now, I want to encourage every person listening, because you might be knowing someone who is pregnant around. Please, after delivery, it's very important that you visit the health facility. And we always say that within 6 days after delivery, go. But you don't have to wait for the 6 days. As soon as you're feeling any abnormal feeling, go to the healthcare worker. Because until we are able to investigate, you tell us that I was feeling all right before, but now I'm starting to experience ABCD, that we start doing the investigations that we have to do to find out what actually is causing this problem within this mother. But there are multiple things. And what you said, having a fever, one of the things that we have to be sure is this mother having sepsis. Because one of the clear sign or symptom for a mother who has just delivered getting a fever is sepsis. And remember, we said it's a third cause of mortality. So we have to investigate and say that could it be sepsis, or is there something else that is causing this fever? As a country, we still have malaria. So we have to be sure that we are not dealing with malaria. Sometimes we don't want to overlook some of the common things in our midst. But remember, I also said that a mother can have everything okay, but after delivering, then their blood pressure shoots. So we can only capture that when a mother attends postnatal care. But also the other issue is, everything can be okay, we discharge you home, and then you start bleeding.
Do you feel like us as a country, or mothers of this country, have appreciated the delicacy around pregnancy? Because you have mothers telling you, I left hospital, I feel fine, I'm just going to go to my garden or do whatever I want, I just feel so good.
Of course, for me, and I want to thank you, Viola, and the entire NTV for really hosting me here, and the Bill and Melinda Gates Foundation. We have to do this kind of conversation continuously. But also want to see, because we have many of our mothers who may not be able to get the screens, who may not be accessing NTV. So as a ministry, we are thinking very hard. You know, when I get these calls when I come here, it pushes me to think that as the ministry, we need to do a little more in pushing the message out there to every single Ugandan to appreciate it. So in terms of packaging our message and ensuring that it reaches every person, as far as pregnancy and childbirth is concerned, it's something that I appreciate as a ministry we have to do, to still have to invest in more.
So we have a phone call, Doctor. NTV Medical Matters, who is there? What's your name and your question?
This is James Marking, yeah?
Yes, please.
My question is, what causes false negatives or positives during pregnancy and later on the woman delivers normal?
Okay. Okay, thank you so much for that, James.
Yes.
We are capturing more questions before we leave, so if you have any question, please call in. This is your time, NTV Medical Matters. We can talk about a few of those and then we shall get out of here. Our time is up, so if, okay, good, you're in time. What's your question and your name?
Yeah, my name is James from Kasese.
Okay, what's your question?
My name is there some blood in the private hospital?
You got that?
No.
Could you repeat that, please?
Is there some blood bleeding in private hospital?
Okay, thank you so much for that. I believe we can take these two. Thank you so much, our callers.
Yes. No, thank you, and I still I thank the men who have called in. Yes, I really thank the men. Now,
okay, we have one more.
Hello.
What? Yes, please, I can hear you.
Hello, my name is Miriam.
I can hear you. What's your question and your name?
My name is Miriam. I'm calling from Congo.
Yes, please.
And I would just like to suggest that it would be good for the Ministry of Health to use the local community radios in order to reach the people that are not watching on TV. It's a very, very important or very, very pertinent program.
Okay.
Especially for our rural mothers or mothers who are out of country.
Okay.
But community radio, because they hang in markets and so on, if they could access those, because people listen to those radios in their markets and their stocks, and they're doing their work even at home. They listen to those radios. I wish we could use those community things that can help to make this information get further.
All right.
Yes, NTV. Thank you.
All right. Thank you so much. And thank you for watching NTV Uganda. Wow, that's a very nice one.
Very powerful suggestion. How much time do we have, Viola? Because I can speak until tomorrow.
Keep going. Let's do that.
So, and I'll start with the lady who has submitted. And thank you very much indeed. So, as the ministry, we realized that we needed to amplify our voice. So we dedicated months for campaigns that are targeting the leading causes of mortality. So we have 3 months. We have, there are 4. We have the Safe Birth Awareness Month every March, which is the month of women.
True.
And what we do in that month is we try as much as possible within our local maternity and neonatal systems to get down to the grassroots. We try to take the conversation out of the hospital. And as the latter callers indicated, that we will ensure that we are getting to the community radios and relaying the message through the community radios to our mothers who are not able to see us on the screens. So we will try to do that within those months. So we have Safe Birth in every March. We have every May we discuss preeclampsia, high blood pressure, and the conversation, healthcare workers, communities. The entire month of May, we're discussing high blood pressure. In August, we're discussing excessive bleeding. after childbirth, and in September we discuss sepsis. So we've tried to, as a ministry, we've tried to dedicate months to enable us send a message out there. But I like the suggestion of the.
We hope you invite us the next time. We'd love
why
to
wouldn't
be there.
Why? So we will make it a point. And I liked the gentleman from Kasese. So for a private facility to have blood, there are particular processes that they have to go through. Of course, one of the challenges that we had was blood being sold. And now that was a very critical issue. So as a ministry, and for all the time we've been here, is before a private facility, even the government facility, accreditation must be sought from the Uganda Blood Transfusion Service, which controls collecting, processing, and distribution of blood. And as soon as that private facility is seen fitting to be able to transfuse, because there are particular parameters, including the facility must have, storage facility for blood, but they must have power backup because that storage facility must not go off. That blood is kept at particular temperatures, which must be maintained until the blood is transfused. So the facility is assessed by the Uganda Blood Transfusion Service, and if it qualifies, then they are given, and that's for whether public or private. And James asked a very good question. What are the causes of false negatives and positives, and let the mother delivers normally at the end of the day? And we've had such situations where, you're with a team, the mother attends at NATO and she said, we don't think you'll be able to deliver normally. We think there are particular absolute, I'd say, indications that we cannot allow this mother to deliver normally. Those ones are clear. There are those that are clear. But also there could be some situations where we say, okay, in this kind of situation, let's give it a chance. And we see how she progresses. And one of them is the other issue. Your first delivery was cesarean section. The second delivery, you're just basically trying labor. You may not deliver. But so there are those situations that we have to assess. But very importantly is if a mother is delivering in a health facility, constantly, as soon as labor starts, we have to check, and sometimes it's not the best thing, we check down and we say, oh, you're at these centimeters, let's give it this bit of time and we see. You get my point? So because there are a number of factors. One is the mother having contractions, is the baby lying quite appropriate, but also is the mother's pelvis and bones adequate enough to allow this baby come through. Okay, and this is where we're going to stop our conversation for today. I know that we can go on and on and on. This is a very, very interesting one, but whoa, thank you so much, Doctor, for your time, for coming here, and for your insightful conversation. We shall call you back, most definitely, because we have so much to talk about maternal mortality as well as the journey in pregnancy. And thank you so much, dear viewer. This is the end of our time. We've really tried to stretch it, but thank you for callers. Thank you for everything and for being a part of NTV Medical Matters. My name is Baela Kusasira. Every Monday at 10 a.m. we are always here and we are discussing very impactful topics here that are happening in our communities, and you and I can testify that we have seen this. You saw Sophia's story, and she's one of the women that are struggling. Knee pain, back pain, heavy bleeding, just so much more, So catch us next week at 10 a.m. and we shall be here to bring you the most relevant topics here on NTV Medical Matters. We are supported by Bill and Melinda Gates Foundation. I am Baela Kusasira. Have a wonderful